how to do good composite reconstructions. And that's something that you need to do if you want to do reconstructive work. You want to be doing composite work. I see a lot of this composite has been beaten out of proportions in everyday material. The trouble is, when you're talking to these guys who do these composites, I hardly see the space that this smile complements. It's all about retracted views. It means nothing to me. You see, it doesn't mean anything to me, because if let me put, if I'm going to see a beautiful face that's going to look right, it's in composite. Let me see if I can, just give me a second. I'm going to see if I can bring this patient up, if I can find it. Just 1 second. It's always interesting finding things, isn't it? Let me see if I can find it. I'm going to go here. I'm going to go Susie. 1 second. Susie. Susie. Hold on, wait, just 1 second. Not this one. I'm going to come out of this one. Ask me questions while you're there. Any other questions? I'm happy to answer. Isadora.
Dr. Sarkis, one thing that I really remember from your teaching is that you say there's only always one diagnosis, and there are many different ways of how you treat it, and there are many solutions. And I just feel really resonated with that, because if patient comes to you and they have something in mind that trouble them as a problem or their concern, if you cannot really detect that and work around the reason around it and give that definitive diagnosis, then it's very difficult for people to actually buy in and listen to you and build that trust.
True. Very true. And it's well said. I think it's well said. We're ready to go.
Yeah, we're ready, Dr. Sarkis, if you...
Fantastic. Well, thank you. Thank you all for coming to the webinar 11. We discussed a bit about the college. I'll talk a bit more about the college later on. I'm happy to talk about this. Today's webinar is about a patient who presents age about 30, 35 with a problem. She's not happy with the appearance of her teeth. There's a history of orthodontic treatment in the past, and the problem I see is we can obviously see that when she smiles, she's trying to hide the smile. I mean, this is the anterior negative space here, and she's hiding a smile. And naturally, with time, you feel like this too is migrated forward because you might be biting on a lip, or is a lip biting habit. Well, we're going to discuss today is how do we assess this patient. We're going to discuss looking at the how do we diagnose concerns and trying to look at our treatment options, both short term and long term. And I'll be able to raise some questions in your mind as the possibilities of treatment and bringing a bit more excitement into the equation, because it's to see how this case is going to develop and how we find solutions. And we teachers at the college, one of the reasons I like talking about it is the fact that it's a reverse smile line. And a lot of you know what reverse smile line is. We can discuss a bit later on. But do you know what the cause of reverse smile line is? Anybody can help me with this?
Any trauma or something like that?
Trauma?
Because I think the central incisor, maybe the lack of space, but I think maybe there is a history of a trauma before. I'm not sure, but we need to get a history.
Okay, this trauma would be a good idea. Any other areas? And would you say trauma would be which tooth, in your opinion?
Yeah, I think
so.
I'm listening.
Natural relaxation before. I'm not sure.
I'm sorry. Just 1 second. I can't. Nimesh, you have to mute the background noise.
Yeah.
Okay, Pune, please proceed.
I think maybe lateral. We need to get a history from the patient. That is there any history of trauma in the anterior part? And because of the bite of the patient, it could be a little bit open bite. So I think maybe it could be genetic, and we need to ask the patient regarding any, for example, misalignments from siblings or father, mother. We need to get a complete history from the patient, especially I think trauma.
Okay, that's good. Any other causes of trauma that you may see?
Sorry?
Not trauma, any other causes of reverse smile line?
So possibly, sorry to cut in, attrition, tongue thrust, anterior open bite.
Anterior tongue thrust will cause anterior open bite. Where else?
Tongue thrust.
Bruxism.
Tongue thrust. Okay. If Puna, you mentioned trauma, and I accept that. If there was a trauma, which tooth you think would have the trauma hit it?
I think the right incisor. I think it has got a trauma because it seems that it could be a lateral, maybe luxation. And I think it could be, and we need to get a complete history from the patient.
Right. Okay, you're saying, okay, understand that. And any other comments at all?
You said she
Where
had
else could go anterior? I mean, there's a bit more there. Where else? We talk about anterior tongue thrust by Isidoro. Puna, you mentioned about trauma, and I accept it. Okay. What else could cause inflammation? I want all the possibilities that comes in your mind.
Bruxism.
How would bruxism cause that, Isidoro?
So edge to edge wear on the anteriors.
Anteriors, okay. So that's a tooth surface loss, correct?
Yes.
Right. So you say, instead of saying bruxism, you would say tooth surface loss, because tooth surface loss has many other causes, and bruxism one. Okay. I'm just trying to put it in the right form. Okay.
Tooth surface loss caused by erosion.
Erosion, and it's a tooth surface loss, irrespective. Could be erosive, could be, dysfunctional. What other dysfunction you think will cause this? I want you to look really carefully about the top picture. What else could cause it?
It could be habits. Someone's biting on a finger and pencil biting.
That's right. Pencil biting, big biting.
Yeah,
Correct. Very good. Very good. I'm going to get it out of you anyway. I'm going to get it out of you. There's no question about that. I will promise you, as a teacher, I will get the answers out of you because you all have the answers. Okay.
Dr. Sarkis, I can't see your screen.
Yeah.
It's
just a slideshow.
It says resume slideshow. Can you just press on your slideshow?
Yeah, of course.
Hang on a minute. What do you mean slideshow? Just a minute.
Just click on the slide. I think you need to refresh the screen. Okay, now it's
there
good.
you go.
Yeah, thank you.
My apologies. So, lip biting. Thank you very much, Natasha. Okay, what else? I want you to start thinking. Patient presents in your practice, this problem. He's talking to you like I'm here, and and so I'm talking to the patient in my consulting room, and my PA will write a few notes, and I will say, if we talk about the rascal, so I'll ask you questions, right? I ask you questions, and we talk about the tooth loss, okay? And you all have said this. You both have said this. Trauma's there. Pune, trauma's definitely there. It's coming up soon. Okay. And well, we talk about the anterior open bite. I think you mentioned anterior open bite. It's caused by what, anterior open bite?
Anterior surface line.
What causes anterior open bite? Quickly.
Tongue thrusting.
Tongue thrust habits.
Anterior tongue thrust. Correct. Anterior tongue thrust. Not tongue thrust. Anterior tongue thrust. Could be lateral tongue thrust. Whoever is a lateral tongue thrust, all right, you got a lateral open bite. Okay. So we got to get it right. So it's anterior tongue thrust. I agree with you, Nimesh. Okay. Next one. Nimesh mentioned about dysfunction, correct? Flat and maxillary incisors could be genetic, as Pune also mentioned. And you got dysfunction, all right? So thumb sucking, the thumb, and, okay. I like a little bit more. Trauma's there, Pune. I know it's trauma. I like a little bit more. There's something else. Two more things I want.
Why does she have composites on the incisors?
That'll be
Yeah, both there are composite field. Yeah.
that'll be later. You're watching it, but I want more. So what else?
Narrow maxillary arch, doctor.
Yes, that's fine. That's genetic. I agree. That's genetic. I didn't put genetics here, but narrow maxillary arch is also a problem. Developmental, correct? I should add that. Developmental. Well done, Vivek. Developmental. Where else?
Have you got a relapse from ortho or what?
Well, this is past autonomic treatment. You're right. I had autonomic treatment.
Yeah.
So this is relapse, but that's not the question I want.
Okay, no, that's fine.
I want you to think globally. Okay, she's about 30, 35, comes in, anterior open bite. And let me throw another equation there. Okay, another span in the wheel. She said, this has developed last 5 years. Okay, what would you say? It's last 5 years developed this. What would you say?
I think it's more likely it's something localized happen, because it seems to be that just one tooth for example, lip biting can exaggerate this condition, but because there's no seal. But I think it's more likely it's a localized, something localized, like any habits.
I agree.
Yeah.
Well,
for example, if you want to think that she has got orthodontic treatment, she has got both four, premolar.
The premolars are there.
Yeah, so most likely it's a habit or it's a cause of trauma.
Okay, but I want you to think, I agree, habit, trauma, cover those, but what I want you to think is, what else can cause it? Not for this particular condition, what else can cause the, anterior, flat anterior incisors? What else can cause it? See, when a patient comes in and they're talking, my brain starts firing, right?
Perio.
Perio, who said that?
But she has no problem.
Well said. There it goes. If you have a periodontal bone loss, you start to lose your posterior support, right? And teeth come together and they can splay the teeth. Naturally, there's an anterior open bite. Okay, but I'm just saying it could be one of the possibilities. If there's anterior bone loss, then anterior tongue thrust, if there's any residual tongue thrust, that will also cause a, splitting of the maxillary incisors. So periodontal consideration is a must, because with young patient 30, there's a serious problem with anterior flaring if it's last 5 years. See, the things that be considered. We're looking at teeth, looking at tongue, looking at lips, we're looking at the gums and the bone that's supporting it. Good. One more thing I need. What else do I? What else is causing flaring of the anterior? Where else can? I want you to start thinking globally, right? Not locally. I want you to look at the outside the square. One more thing that can be really that's alarm bells go. James said, last 3 months, my upper anteriors or my front teeth have started moving forward. Last 3 months. I'll start getting alarmed. What could cause it?
Does she have obstructive sleep apnea?
No, she hasn't got it. That's a good question. No, that wouldn't cause the flaring of the anteriors. Just a question, hypothetical question. What else would you come in your mind?
Any splints, anterior splints?
I'm sorry, Ravi, say it again.
Anterior splints wearing like an anterior splint?
No, she's not wearing anterior splint. I mean, basically, I'm saying the patient comes to you, last 3 months, my front teeth start moving. Okay, perio will be one of them. I will think of other things as well. It's just, you gotta look at you see, when you do the differential diagnosis, you gotta look at lots of things, right? Lots of things. So I want you to think of lots of things. That's part of diagnosis, okay? You see, like when I look at the Instagram and I look at a lot of Facebook that people post, they missed a lot of other issues that they missed. They're actually concentrating on the cosmetics. And a lot of
Dr. Sarkis, someone in the chat just said an OPG to check for cysts.
Say it again, I'm sorry.
Someone on the chat said an OPG to check for cysts.
OPG affects the cyst, okay. That's fine, but what would OPG say? If you took an OPG, very good. What's OPG good for?
She's saying to check for any cysts.
For cyst, okay. But does OPG show you a really good on the anterior maxilla? Does really show the image really well anterior maxilla?
No, actually not really.
Sometimes it can, because I'll show an OPG later on, but sometimes it can't, right? Depending on your focal trough and how you position the patient on the X-ray to get that effect. So that's fine. Okay, let's say if you found the cyst, where would the cyst be? Will it be on 1-1, 2-1, 2-2? Where do you think the cyst will be?
Would you please ask your question again?
Okay.
So cone beam, I think cone beam is the best one to evaluate any existing.
I agree with you. This case is about 15 years old. So I didn't have cone beam then, okay? So we have a simple OPG, and now so I'm going to bring it up. But you can do a lot with simple stuff that you have in your practice. So what I was thinking is, you mentioned cyst, and I think cyst can be, next stage would be like looking at some sort of neoplasia. If someone come to me in last five months or 3 months, they're moving teeth, I'm thinking of everything. There's a number of neoplasia that can make the teeth loose. So that needs to be taken into account. Okay, there's a trauma at the end. So, and there's a past orthodontic treatment. So am I making sense in terms of the importance of doing a diagnosis on a grand scale where you're able to see this patient? And the patient is actually unable to smile, and she wants to go back into the community and meet a nice person in life. So let's go to the next slide for the patient. We talk about reverse smile line, and let me just define reverse smile line, okay? And reverse smile line, we have a reverse smile line, and it's an unhappy smile line, and we know about this. The other thing was with orthodontic treatment, they try to move the anterior tooth to a certain level. They actually did a surgery. They tracked the tooth down into the arch and left as it is. And Ravi mentioned correctly that there's a composite on the 1-1 and 2-1. You can see that. And you wonder sometimes, why would someone place a composite on those two front teeth? I mean, it's strange, but she's been living with this. All the other teeth are fine. So it makes you think sometimes is what are the possibilities in terms of, what people, do to the patients, and patients will live with this. But having said this, I'm going to bring to the next slide. I think it's very important we discuss the next slide. So you all agree that this is a reverse smile line, correct? You all agree on this. Good, good, good. Let's go next slide. And the next slide is an interesting one because what else do you see that's a big concern for the patient? Now we go to the patient level. What else do you see is a really big concern for the patient?
Can't see your slide.
You can't see my slide. Can you see it now?
Yes.
Thank you. Thank you. What else do you see as a big concern for the patient?
Of course, the patient firstly think that one of the tooth is shorter. Because it's a little bit out, so most of the time the patient think that my teeth are not level, and they don't have that the same size. The first thing that they mention, always pay attention to that. And the other concern, there's because of the gap between upper incisor and lower incisor, maybe it could
right. Okay, so when you're looking at this patient, would you just consider the upper arch, or would you look at the lower arch as well?
We need to take a look at both, because we need to have a straight line, especially the central incisor. The plan should be parallel to the floor or lower lip, but we need to divide the space, and because sometimes, for example, lateral in the lower arch, there's the rotation, so it can exaggerate the space, right, because it has got a rotation.
Okay, let me I'm going to say something else just to put you guys in the right sort of format. If you look very carefully here, what do you see? For instance, do you see that? Can you see that if I draw a plane of the upper arch and look at lower arch, the lower lip and the upper lip are pretty symmetrical. Would you say that? Would you agree?
Yes.
Yes. So, and we're looking at the top and bottom arches. What else do you see here? Do you see anything that's a little bit different when we start to restore this patient? Let me give you a hint. I think it's okay. You can see if I draw a line of the occlusal plane, it's actually canted. So left side's higher than the right side. Would you agree?
Yes.
Provided there's the interpupillar line is correct. It's correct. Let me tell you, it's the horizon. So this is canted. Okay. So we have a number of issues here. When she drops, you can see the crown margin of lower molars, right?
Yeah.
Can you see that?
Yeah.
Okay, so you know sometimes when we can smile, you can see the full upper and lower arches. This is a complex smile line. But what I'm saying is any treatment that we do on this patient has to look Schmidt. In other words, top and bottom teeth are on the show. Okay, so if you just do the top, maybe yes, maybe no, but you go to the bottom as well. Okay. Now there's a number of issues about what I want to, but in terms of trying to create a nice smile line, I agree. But the question I like to ask you, what really the patient's asking, because they can't really express themselves, is trying to get this anterior negative space. So whenever people have a smile line, there's also negative space in the lower arch. Okay, it's this negative space that's most disliked by most of the patients. Okay, Jean did this famous little study where he measured a lot of people. They said the worst smile was the worst smile line. That's an old study, and a well-quoted study too. But this is what you know, has been in the literature for some time. It's called unhappy smile. Okay, even when the girls at the front grill's done, they try to make a happy smile because that's how you think. Okay, having said that, I'm going to move to the next slide. So what's really happened is, if you think about, if you had to go back, and this is the problem too, isn't it? Is that correct? Is this a real problem too in the art?
Yes.
Yes, thank you. Okay. Now, a lot of you would think about having a clear aligners of any type. You could easily correct the upper and lower. You can actually now click and bring and close the open bite, correct? You could do that. Kathy, are you there?
Yes, I am.
Yeah, I mean, you could close, if you could easily close this open bite, couldn't you? With clear lines nowadays, right? Because that's the best thing to do. They can overwrap. They can don't necessarily intrude. They can overwrap, and you can close the bite. You can get some lovely result for the patient. And the patient say, "Wonderful work, you know, doctor, and I thank you, and I'll refer you all my family and friends." Which is a good thing to have. Now, let me just throw another spanner on the wheel. When we look at this patient's X-ray, what do you see?
I think it's
What do you see?
I think it's because of trauma. It's a lateral relaxation.
Is it laxation?
Before.
Mm-hmm. So all the teeth are fine. Hair is good. You know, care is control. There's a little bit of a problem here that needs a bit more work, and there's a aspect that's been cleaned up, but everything's fine. So you get that tooth one. So how do we go about, now what else would you do on this patient? I mean, we haven't got to come in CT. I'm going to help you with that. I'm going to really help you with that. So, I mean, we know what I'm talking about. We have a problem tooth here. And I think the orthodontist did a fine job trying to position that tooth in the right level. And we think, I'm just going back to the other slide and lower the other slide. You can see that these gum levels are not too bad. Okay. This tooth was up in under the nose. It was brought down into this side. We've got good gum levels. So I think the orthodontist did a fine job to position those gum levels. I'm just trying to make you think, that's all. Okay. So how do we treat this patient? What view would you like to see from here? If I had to show you a view, what view would you like to see?
Anterior, posterior.
Anterior and posterior? Which anterior view? If you had to examine a patient, what would you want to have a look? See, I like to palpate things, right? I like to feel things with my fingers so I know exactly what's happening. What would you do?
we shouldn't have any swelling in that area.
We should. I'm sorry. Can you say that again, please?
Swelling.
Swelling in that area. What sort of swelling will it be?
You know, we have a lot of bone loss around the lateral.
You have bone loss around lateral here? Here?
Yeah. So,
yeah, right. Okay. And there's a bone loss there? No, there's a bone loss here.
And also here.
And also here.
But, yeah. And.
Okay. How do you know there's a bone loss here? Just purely because it's not as dense? Would that be correct? Because it's not dense, right?
At the apex area in the right lateral incisor, we have more bone loss.
More bone loss, right. And what would that be in your opinion? So let's say your patient and we're saying we got a bone loss here. But before I do bone loss,
we need to do vitality tests, of course. We need to do vitality tests, pressure tests, tap the teeth.
Periodontal pocket charting, right? Okay.
Yeah.
Let me. Yeah. Charting shows there's a good level of bone here. What you're seeing is the OPG view, because those two front teeth are on the same trough as the rest of them, and the laterals are a bit further back. That's why you're not seeing it. And I accept that. I understand that. They're just a little bit less dense because the OPG trough, the tomogram, is not going through the lateral. That's why you're seeing it. But ours is not bony, I can show you. But having said that, and I accept that, in your opinion, what's happening here? Can someone give me an idea?
Is there a horizontal root fracture?
Okay. Okay, horizontal. Any other differential diagnosis?
Was the tooth loose? I mean,
no mobility. No mobility.
No mobility.
No mobility.
Your slide.
What else?
The bank will just say, well,
Yep, go ahead, please.
Someone suggested resorption.
Resorption where? At the top? Possible. But how can I go this line?
Horizontal.
Maybe like cervical resorption.
Cervical resorption? Interesting. Okay. If there was cervical resorption, what would you see? If you should classify cervical resorption, there's different types, but Natasha, your Adelaide colleague would have told you all about it. Any other?
There is no irregular margin I can see, so it's not a resorption, I guess.
Resorption, no, that's good. Very
Is
good.
widening of PDL is there?
I'm so said again.
Widening of periodontal ligament, like widening of lamina dura.
Is this a ligament? I'm just looking at the ligament here. There's normal mobility. If I look at another ligament, it may look widened. Yep. What does it tell you if it's widened? So what does widened periodontal ligament tell you?
There's some sort of force.
Some sort of force.
Unfavorable.
Okay, unfavorable or physiologic force. Okay, so there's no bone loss here. Okay.
And regarding the pulse, did you test all of the tests?
It's vital. That's tested. Yep, it's vital. All the teeth except the RCTs are vital.
So the widening of the PDL area could be related to any dislocation. So we could see like that.
Okay, well, remember, I said to you maybe a trauma as well, but let me ask you a question. See, so far, you've seen the smile, you've seen the x-ray. What would you want to see? What do you want to see? Would you take a cone-beam CT or would you do something else before that? Should we have cone-beam CT? This time we have no cone-beam CT.
Take a periapical radiograph.
Okay, now, all right. Let me just give you an example. Okay, I'm going to talk to you about next one. What do you see? Same patient. And let me help you. What do you see here? That's different.
Lip is puffy.
The lip is puffy. Why would that lip be puffy?
There might be some underlying swelling around the dental villar area.
Cyst.
Oh.
Yeah.
Cyst, yeah, okay, could be. Yeah. So how would you know if it's cyst or not? It's a big swelling for a cyst. I mean, this is serious stuff. The cyst is that big, okay? The cyst has to be at least about maybe 15 to 20 millimeters in to be able to get that. I've seen some big cysts. Okay, and the X-ray didn't show any cystic formation on the RPG. We know that. So what else was there? Why is there swelling here? There's an asymmetric upper lip from this angle. So what else would you like to see? What else would you do in this situation? Here's your patient. I've been wide looking. Oh my God, the lip's fallen there. What else would you want to see? What view would you like to see? You've taken your X-rays. Something's not quite right. Patient comes in. What view?
Occipital, doctor.
Huh?
Occipital.
Occipital view.
Have we got a PA yet, Sarkis, of 1-1?
Let's say you got a PA. Let's say if I expand, I'm going to show you the PA in a minute, but I expand the RPG because this is a 15-year-old case. Okay, but what is it? What else would you want to see?
Occlusal view.
Occlusal view. Yeah.
Lateral view.
Well, you see, I'm trying to make your life simple. Most of the things are very simple, okay? After the view I want to see is this one here.
There is a swelling.
What's this?
It could be related to any minor salivary gland. If the tooth is vital and
If it's a minor salivary gland, possible.
yeah.
Neoplasia, but what else do you think is happening? But I can tell you there's no neoplasia. I'm trying to get you guys in the right format now. What else could be happening? I mean, and let me tell you what it feels like. It feels really hard. Okay?
So it's hard?
It feels very hard and there's no pain whatsoever.
Is the root deflection there because of the trauma or something? Is the root sticking out there? No.
Maybe. What's it called?
So we have some opacity at the apex of a 1-1. So it could be related to any underlying bone problem, especially in anterior area. The patient, was the patient white? I mean, Caucasian or some?
Caucasian, she's Caucasian.
Caucasian, okay. 35.
Someone suggested scar tissue.
It's a hard tissue. What would you differential diagnosis here on the hard tissue? What could it be? Could be odontoma, could it? Yes?
Peripheral.
It could be odontoma, but there's no odontoma on the X-ray showing.
No.
Okay. Okay, it's not odontoma. I mean, you think about it, there's complex or composite odontoma. There's two types of odontomas. There's no other tissues here, I can't see it. Assume there is none. So what else is happening here? Have you mentioned trauma? And Nimesh mentioned something about changing. What else is happening here?
There's also a suggestion for root dilaceration.
All right. Is that right? Very good.
Yes.
Very good. Very good. This is dilacerated. That's right. This is the lacerated root. At what age do you think this will sustain to create a 90-degree angle between the root and the crown? That's actually part of the root sticking right out. It's more than 90 degrees. It's bent. What age would it happen? How would you find out? What would you ask the patient?
Around 7 to 8 years of age.
7 to 8. When does a central incisors root formation complete?
10 years.
10 years. When does a crown calcification complete?
Crown calcification.
It's a hard question, this is I'm asking, but listen, let me help you. About 4 years of age. So you asked the question, and how would this occur?
Laceration?
How would
It's
it
because
occur?
of the trauma to the
Primary.
primary teeth.
What position these two would be to sustain that sort of trauma in relation to apical part of the primary root? 1-1. Or
Mostly the permanent teeth are located in the lingual area, in the posterior area of the primary teeth.
right, very good point.
So,
well said, absolutely. So a trauma would have knocked this completely out, right? Could be in and it will bend the whole thing. Yes, right. That would have bent the whole thing. That's right. So this is actually more than 90 degrees bend, you're saying it, okay? So the orthodontist did a marvelous job to bring this tooth down. Would you all agree on that? Thank you. Thank you. The next question would be, is that patient wants to restore teeth. So imagine if you promise this patient that I'm going to do a crown here to put this tooth in the right place. What would happen to the vitality of this tooth? Chance of losing vitality. What's the chance of losing vitality? It's almost like 35%. Okay. And what happens when you lose vitality? What do you do to the tooth? A root canal therapy? What would be the success of root canal therapy with this complex behavior?
it's very difficult, yeah.
And so, and then you have the so-called implantologists will say, we're going to take the tooth out and put an implant, right? Let's just leave that for a second. Let's go next slide. So the treatment would you recommend? I want you to think about this. Okay. So what would you recommend for this patient? She wants cosmetic, she wants to smile. Doctor, I'll come to you and I read all these beautiful reviews about you on your website. And then you're the guru. Please fix my smile. I want to smile. I want to get on the marketplace. I want to feel good. I'm so depressed, can't smile. And she's a bubbly personality, very charming lady. And what would you do?
I think the first choice, for if she was my patient, the first choice, I referred the patient to the orthodontist for have a consultation. I think the first choice is any orthodontic treatment, and the other one is that we a little bit over contour from the facial area of the lateral and the other central incisor, and also two laterals and one one and two laterals for a little bit level the problem. But the problem is that the patient has got a problem and open bite in the anterior. So the space is still there. So the smile line is still not level, and there is open bite again.
Very good. Keep going, please.
So I firstly refer the patient to the orthodontist to have a consultation. If in that case, if it wasn't possible.
What would orthodontists do in your opinion?
Sorry?
What would the orthodontist do in your opinion? What would you suggest? What would you suggest?
To orthodontist?
Yeah, what the orthodontist would suggest as an option, because don't forget, patient had orthodontic traction for almost like 5 years. Okay, so you're going to tell the patient, I want to send you to orthodontics, and let's say patient agrees in this scenario. What would orthodontists do?
Maybe extracting 1/4. And
why extract 1/4?
Sorry?
Why would you extract 1/4?
Arch expansion.
Yeah, to have more space and to keep the 1/1 into the arch.
Can you go forward anymore, in your opinion?
Sorry?
Can you move 1, 1? Can you actually, would you consider putting a bracket on 1, 1 and moving it?
I don't know if the 1, 1 can withstand any more ortho treatment.
They can't go for the bodily movements.
I think 1, 1's headed. I wouldn't go near that too. See, let's say it's vital. You see, anything else with that too, you're going to cause a major problems. And I understand where you come from. I wouldn't think the orthodontist will want to take 4 teeth out for this patient, because or 2 teeth out to bring it in, because with the anterior closure, if you've got good arch, I mean, normally if the teeth are vital, there's no reason why I can't use clear lines to bring it, but you've got anterior contrast, so the patient has to contrast, train, a lot of other issues before you can do that, because there's a visual opening. But
Dr. Sarkis, Beverly suggested, how about extracting the 1, 1? Would they suggest that, the orthodontist?
I think it's extracting 1, 1. Let me talk to you a bit more about this. Can we just take that notion, and I want to come back to it. Okay, we're looking at the oblique views of this patient. Okay, you're looking at the oblique views of this patient, different angles, different views. Okay, and what do you see here? I mean, what am I looking at? I mean, in terms of, let me ask you another question. When a patient presents in your practice, what I would normally assess is that not what's wrong with this smile, I will assess what is right about the smile. And what's right about the smile, Nimesh, proceed. What's right about the smile? Izzy, you're next, and Kathy, you're after.
See, I like the left side is more symmetrical than the right side.
Okay, okay, start from the outside, go in, okay? We're going to talk about start from the outside and go in.
Okay, let's talk about the lip, of course.
Lips are good?
Yeah, so the lips, of course, it's a short lip appearance because of the procline teeth and all that.
The lips are symmetrical, yeah.
Yeah, so the lips are fine. We need to work on the gum symmetry. The tooth display, I can see, of course, both upper and lower. So I want to keep that in mind. That there's a bit of display of teeth. Of course, the right canine is a bit more prominent there. But considering, of course, I'm still not jumping into treatment, right? I'm just...
No, you're not jumping treatment. We're not doing treatment, no. I want
okay, not yet, yeah. Okay, so the width of the 2 centrals is looking quite promising to me. Of course, there is a 1, 1. I still have a room to adjust if I want to. Okay, and of course, the laterals are good in shape and symmetry.
Done.
So, so overall, I am happy with the. I'm not looking into going any or. Okay, now don't go into treatment. Sorry, I want.
Isidora, you're next. Go ahead.
Okay, so I'm looking at the smile. I think the position of 2, 4, 2, 5, 2, 6 is good. Even 2, 3 is not too bad. I certainly think that the anterior or the upper incisors, all 4, would benefit from some extrusion. 1, 3 is a little bit too prominent, needs to come in. Also, the gum, we're getting a lot of gum showing on the upper right, so we need to work out what is gum asymmetry.
Right.
So it's a gum asymmetry on the upper right.
Okay, so that's what's right. We know what's wrong with the smile. Kathy, thank you. Is it Kathy? What else do you see?
First of all, that I feel the upper midline is shifted.
Right.
I do want to look at the lower midline, kind of like 3, 1 mesial is more towards the right place, but somehow the root angulation is so tilted. If I look at the occlusion on the left side, I see a slight crossbite when it's slightly open. And on the right side, that I do see the curve of Spee. The posterior, the premolar side is not so good, although I think the 1, 3
that's
is
because of the canted maxilla, right? It's got a bit of a negative. Yeah, because of, I agree. But
yeah, I feel like we have so many
that's right. But
reference point. Yeah.
Of course. But can I say that the midline is about right, which is the maxillary midline is about right. Is that right?
It just tilted. Yeah.
See, we talk about, to me, that I look at this patient. What's right about this patient? That's about right. I agree with prominent 1-3. I agree easy. Okay. The mesh lips are fine. I agree. Okay. Kathy, I agree with low 1. But she got a tongue thrust. Can you see a tongue thrust sticking at you? Okay. Yeah. So if you want to do orthodontics for this patient, first she's going to refuse, number one, because it's just a trauma. Okay. And you put her forward. That's part of the option. Patient, no, I don't want to, is there another way? Okay, this happens a lot in my practice, and I'll do this conservatively. Naturally, I love to move the lateral a little bit out and bring the canine in. You can do that with aligners, yes. At the time, we had no aligners, so that was not an option. But to me, you know, I would have done that. I would have just lined this up a bit better. There's no question about it. I would line the low ones as well. I agree with all of you. I'm looking at on the right side, on the right slide, looking at her on the lateral oblique angle. I can see a really nice progression. I love the lips. Okay. I can see the splayed 1-1 with a large composite. That always intrigues me. You know, like when you look at this patient, somehow this composite has been added on. I wonder where that really composite ends up. I wonder where the lacerated tooth is. Same here. I wonder where this composite ends up with lacerated tooth is. And then, you know, there's something not quite normal here, because with the angle laceration, that doesn't look right to me. So there's a composite labially, and that's really funny because that doesn't make sense to me. So what am I looking for, in your opinion? As I explained to you, I'm looking for what's right about the smile. Now, canal is not too bad. Buccal cord is not too bad, a bit more gum showing. We can sort of play with this. So overall, it's not too bad. That's a bit shorter. This is quite long. So the problem is, here's the patient's level of assessment, right? She doesn't want orthodontics. You mentioned orthodontics, you're going to walk out of the surgery. This wants a conservative way. Can't wait for about 6 months to 12 months. Got a date coming up. Wants to look good. I'm serious about this. This is a real life situation. Let's not ignore it. What we think is ideal for us is not necessarily ideal for the patient. Okay? That's a reality. That's a fact of life. So I'm coming to the next slide. Okay? Here's the next slide. Okay. And we think about this case. We think about this case very seriously. And we ask ourselves, what else am I looking for? You can see the gum margins. She's got a full lip mobility. This patient's starting to feel happiest to gain your confidence. The whole smile's on the show. Imagine if you try to remove this tooth. Okay, I want to see who's the hero, who's going to graft the defect. That defect is going to go up to the nose, and very few people, isn't that fun, from Hungary can have a difficulty grafting this bone. I want to maintain biology. Think carefully. Most important thing is maintain what you got. I love simplicity. I like simple things because they're predictable. I try not to complicate things. I listen to the patient. Naturally, she wants to have this tooth on the left side. Eventually, there'll be crown because of an old amalgam, but it's lasting. Not a big concern for her at this stage. She wants you to smile well and smile with confidence. So to me, as I'm looking at through the whole scenario, I need to find a solution. Look at the open bite here, and you think you're going to close the open bite with orthodontics? No chance. No chance. Would you think about doing orthodontic surgery? 2 years of orthodontics? Orthodontics? You just destroy this patient's life. Okay? She might have a nice smile according to you, but she just lost a lot of opportunities in life. It's not about us. It's about the patient. It's always about the patient. So what would you do in this case to help a patient? I mean, what would you do to help the patient? I mean, I'm thinking in terms of diagnosis, treatment sequence. Stabilize, she's fine. You know, decay, so there's no issue about it. The vitality has been tested, periodontal chart tested. You know, the whole diagnostic phase, definite treatment, all the important things. Remember that wise people know how to bend the rules. Okay? We need to bend the rules for this patient. Where am I going at? Yes, what's the question?
No questions. Keep going.
No questions. Okay. I'll be constructed by the course coordinator, Natasha, to get on with it. Thank you, Natasha. Okay, so we did diagnostics. Okay, so I haven't touched any of those teeth. I mean, you probably wonder how I did it, but you don't have to put composite on the front of the teeth as a diagnostic, it's on the back of the teeth. Isn't it rules that tells you the mock-up has to be in the front? That's our dislike digital smile design. It's absolute misnomer. I want to see the mouth. I want to see the real thing. This is a real smile design. And the patient's happy. Teeth may be a bit big, but everyone, you can see the eyes. The eyes tell you the story, not the smile, but the eyes. Okay? That was a simple diagnosis for me. I mean, you know, are you happy? I mean, it's not the best mock-up, but it's a mock-up. It's enough for a patient to make a decision. And we add a bit more, so this looks good, but nevertheless, we have a smile that the patient's happy with. And then we can digitize this today. We can scan or refine the mouth, digitize it, and then you transfer it to the you know, either exocad or any other smile design for software you have. If you want to play with it, then you can make it right, and you can print a model, and that's your guide. Okay, but I would never go on a computer and play with a joystick, try to make things right. That one's in the mouth. So it's one step less in this way than all the proponents of the digital smile design. Okay, that's my opinion, and I'm very firm on this, and I'm right. Now, so we got a mock-up. I mean, are you all happy with this? Any questions? Can we discuss it more?
So did you add the composites to the front of the teeth or the back?
And the composites on the one on the lingual. You can see the junction here.
Yeah, one in the incisor, yeah, in the incisal part. Yeah, you add composite and you cut just from the incisal, and the line is, yeah, it's a dentin and composite. Yeah, yeah.
Correct.
And then you also added on the 1-2 as well. Is that correct?
I went to 162.6, not the whole thing.
Oh, you've done, okay.
Because I want to fix the car. I still need to add a bit more here so I can correct
yes.
it. Okay, so this more balance as well.
Even the canines, right? Both canines are composite veneers.
No, I'll just add a mock-up. This is not a
veneer. This is a mock-up.
This is a diagnosis. I haven't finished the case. I'm going to show you the case. Okay. I've not finished the case.
But you know how on the first one, the first picture that you showed, the 1-3 was a lot more buccal. How did you get that to be in harmony with the rest of the teeth?
It's just the angle of the photo, more likely.
Okay, all right.
Okay, so that's another thing we'll discuss during the photographic session, how to take a right angle to show. Okay, I agree with you. That's a good point, Natasha. Thank you very much. Okay, so simple mock-up. We'll teach you how to do this. Okay, we'll teach you how to do this in the college. And that's what simple mock-up is. So how do you think, so where do I go from here?
Dr. Sarkis, I have a question. When you do your mock-ups, do you check the bite as well, or is it more just the appearance?
I do check the bite, and I will build all my guidances within my mock-up. Now we'll go back and refine. I haven't refined this mock-up, which is the rough, very rough.
Okay. So do you test things like speech and stuff during your mock-ups?
Yes, speech. And after that, are you comfortable? Is it too full? Or you think I should add a bit more? And the patient's, you know, on a chair for about an hour and a half. Maybe then take videos of before and during and after. Without a college, and the patients given time to spend time on their own, and there's something about the patient bring their partner, or their close friend and give an opinion. But most people are comfortable, so I know exactly what I want.
So you can't really do that with, like, if you do it digitally, right?
No, digitally you can't, because you're not testing the system. And when you do it digitally, people don't really trust you. But when you actually do this mock-up in the mouth at the same time, while in a real time, patients watching you, showing every step, they go wild because they see the doctor transform their face and their smile into a beautiful setting. Okay, and the trouble is you can't do this digitally.
Dr. Sarkis, there's a question in the chat which asks how long and how much would you charge for a mock-up, roughly?
Okay, well, my diagnosis mock-up is about $1,000. Okay, because to me, that's...
But you're a specialist.
I'm sorry?
But that's because you're a specialist. But if you're a general dentist, like roughly?
I have no idea. You just, how much you value your time, how much you value your knowledge, and how much you value your diagnosis. I mean, to me, that takes an hour and a half to do, and that's fair ask. That's an important part of the treatment. People can't afford these. They shouldn't consider any further cosmetic treatment. Part of the treatment. You know,
Okay.
You see, and this
Dr.
is
Sarkis, if I
yes.
may jump in to help assist the charging as a general dentist, I think if you're having trouble to quote a 3 or 4 figure about a mock-up, maybe you can think of it as if like you're doing fillings on the teeth. So say like if you are doing on 10 teeth, and you only charge $100 for the composite direct bonding, it's actually quite a good bargain. So I think it's nice to break it down to the patient, and therefore they don't feel like you're not doing nothing.
Very good point. An excellent point. Excellent point. I think when you ask the patients, and if you go to my Instagram, go to the college Instagram, RCLDP College in Instagram, and there's a patient that we done mock-up recently, finished it. And this guy's a digital guru, right? And I said to him, I said, we can do digital. I don't want digital. That's why I came to you, Dr. Sarkis. Okay, I don't want digital. I just want real thing. So we did a real thing. Amazing. I mean, the results are there. But I agree, because you are the artist. You need to do this. So when dentists do this digitally and get a technician to digitally and print a model, it's you're giving away the control to somebody else. And then determine what your patient will look like by looking at models. Doesn't make sense to me. You need to own the problem. You need to own the case. And that's how you become a good clinician. Okay. Any other questions on this before I go to the next one?
No.
This
happy to move on.
Procedure here. I'm sorry. Go ahead.
I said we're happy to move on.
All right, good. So let's look at the results here, okay?
Actually, there's a question. Aiden wants to know, is the 1-1 in occlusion?
No, it's not an anterior combined.
No.
Okay.
Yeah.
Okay, it's anterior combined. One was not inclusion. Thank God it wasn't. So, but thank you, Aiden. Thank you. Thanks for joining us. Now, we talk about the anterior combined. Okay. All right. So, what I think the question should be asked is that how much of this illustrator tooth is remaining? Would that be right? Okay, so to remove this composite on this illustrator tooth is enough, because the last thing you want is to devitalize this tooth. Is that correct?
Yeah.
So under a microscope, I spend nearly an hour and a half carefully remove all the composite, and that's what we had. So what the dentist really did, he had the composite labially, so that really improves the anterior relationship.
Yeah.
Yeah, it's not simple. All of this is quite forward. This neck is actually 3 minutes in front of that one, the neck. So you have to build the whole thing lingually and match it to the existing tooth. That's the complex. That's the difficult part. The rest of them is not an issue. Now, you can do, doesn't matter what sort of concept you have, but we were able to transform this patient in one visit doing composite veneers into something like this. Okay, and I should think.
Actually, I have a question. When you do your composite veneers, do you shave the tooth down at all?
I haven't shaved any of those teeth. I removed the old any composite remains out.
The distal area.
See a little bit of cleaning here, a little bit cleaning here. So I only adjust a bit of the canine here. I agree here, and a little bit of canine there. You can I'll just shave that a little bit. Okay, the rest I haven't touched.
And just one question in the chat: when you did your mock-up, was the 1-1 in occlusion? As in, did you do the mock-up for the 1-1 to be in occlusion?
No, there's no need. There's no need for that to be occlusion. There's no need. The patient can function well. What the most important thing, the mock-up was because of the anterior combined. Usually patients have listing, and she had listing. That listing was actually improved because we improved the outline, the palatal aspect of the teeth, so you could make those lingual dental sounds, like the S, T, N, all those sounds. That improved. And that was an important part of it. So in many ways, patients presenting anterior tongue thrust, you need to test the speech, because they usually have a speech defect. And if you're improving their aesthetics, you're going to make sure you record that so that you know you haven't changed the speech, because that's the biggest complaint I get as a specialist. I can't talk properly. My speech is gone, whatever. So all this is really, really important. But again, good gums, okay, adjusted, not quite polished yet. There's more polishing, I agree. But you know the result is and I'll give it 24 hours and come back, we'll polish again. And but any questions so far up to this point?
No, we're good for now.
They're good for now.
So regarding the swelling of the lip and your
Still there.
So you mentioned to the patient that inject any filler in their left part, because of this
Swelling here. Fillers, why fillers?
Why
not about the lip? I mean, I'm talking about the lip because the right part of the lip has got some swelling, as you mentioned, and there was an arrow. So you recommend to the patient if there's any problem about the lip and being symmetric, so inject filler for the left part, right?
Well, at the time we didn't do fillers. This is 15 years ago. Okay, at the time we didn't do fillers. But let me show you the next slide. So the next slide is this. Okay, that's the next slide with a full smile. All right. Now, why is it grayscale? Because I want to know that we have the right value of the restoration, not how bright it is, so I want to get that nice effect to it. And the lip bump's not evident as much. The reason it's not evident is because your eyes are more focused on the smile rather than lip. That makes sense? So because the smile is dynamic and it's a moving part, you don't see the lip bump. I only point out because I could see it. Okay.
So are you that the teeth, it's like an illusion that you've created?
Optical illusion. You are creating optical illusion. You see, so we actually, that's a natural tooth there. We add a little bit, but actually here is a big bump. Okay, and I covered this in my lectures for the diploma degree. And you can see there's about 130 slides on this case. We go full on. We explain the whole concept. And this is all built from lingually. You see, I can make composite disappear at that level, that level, that level, and that level. I can make any composite disappear any other level. Having more so, I can make porcelain disappear at that level, and that level, and that level. Because I know how to do composites, and that's what we'll teach at the course. You see, you have to understand physics, shape, form, outline, how the shade is in the shape. You can't make a tomato look like a table if it is red painted. Tomato looks like a tomato, and teeth look like teeth. Central incisor looks like central incisor. Okay. Most importantly is when we're devising this, we need to make sure that the line angles, how much light reflects, okay, from the tooth, and at what position. It has to look right. Okay, how much light you want to reflect. You know that one was lacerated. So I need to work out how am I devising my parameters of smile design. Okay. And how do we create that effect? Okay, so how many composites did I use for this case? What shades of composite? Or what type of composite? It's irrelevant. If you ask me, what type of composite did you use this? That means, wow, I can do this. I just know the type of composite. It means absolutely nothing. What you need to know is how to create the effect. It's called the aesthetic effect, the imitation, the optical illusion. So the observer looks at a smile, says, that's natural look. And that's, it's a natural smile. That's what it's all about. And this is composites. And we did this composites back 15 years ago. And naturally, we'd like to add, this is the initial stage, real light. You can see different effects. I could add a bit more, but you can see the translucences here. That's the effect it created. We can teach you how to do that. There's no magic about this. Okay, there's no real magic, but you must have the end point in mind. And that starts with a diagnostic mock-up. And we have this concept. Naturally, I like to add some color to give it more life. And naturally, here's the patient's smile. Okay, a bit more polishing required, but now we've got life. Add a bit more white spot here just to give that effect. Okay, but to me, that at the time, this was okay for a very simple one-visit dentistry that we're able to change this patient's life immediately.
Did you add anything to the bottom teeth?
Yes, I'll build the bottom teeth as well.
Yeah, they are composites.
I actually did some composite on the bottom.
Yeah.
You didn't want to go. I might bring that. I'll show you right at the bottom. Hang on, where are we here? I'll show you this part later. Sorry. Can you see that or am I gone? Sorry.
Yeah, I can see that. Yeah.
Can you see that one? Let me show you. Resume share. Sorry about this. I'm sorry. Can you see that or no?
Yeah, we can.
Okay, I just correct. Can you see it now?
Yeah.
Yeah.
Okay, good. Okay, so oh, I'm so sorry about this. Keeps bumping off. So we went from here to there. Okay, just adding some little composites. So we added composites on the front of this, and the back of this, the front of this, and the back of that one. Okay, just create that effect.
So you. Oh, sorry.
Go ahead. I'm listening.
So you divide the space, and because you add some composite to the incisal area of the lower incisor, right?
Right.
So you divide the space between two arches, right?
Yes.
Mm-hmm. Thank you.
Okay. So in many ways, it creates a nice effect. I don't have to have a contact between two center incisors. So the gentleman who asked the question about to get a contact with center incisors and anterior combined. When we talk about occlusion, I'll tell you a lot of things about occlusion, and I will remove all the past garbage that you've all been fed with, and I will remove the confusion. And then you have to restore all these cases predictably, because most of the things that actually cause a lot of this problem is occlusion.
Mm-hmm.
It's the occlusion. Now, when we talked about the education we provide at the college, I know that we've talked about wise people know how to bend rules, but wise people also know how to plan for results and not for procedures. So what we teach is how to plan for results. It's not procedure. Procedure is a recipe, allowing you to think and look at outside the norm and look at laterally will give you a lot of good ideas. And this is what college provides, how to think outside the square. Any questions on courses? We've covered that, haven't we? We've got a short course coming up. I was asked to put a short course for the college, and I'm happy to do it just one day. Let me talk about this. Do you want to still discuss the lecture, or you want me to talk about the short course?
Actually, I've just sent the link to the website and to the college email address. If anyone has any questions, they can contact us directly. It's on the details on the chat. So there's a direct link to the website and the email address for more information about the course.
Okay.
If anyone needs any information about it.
For the diploma, right? This is the diploma.
That's for the diploma, not the short course, sorry.
Yeah, I've got a short course. I was asked to give you a short course, and that's this is the course we're going to talk about. And I mean, how often do you get this case come to your practice? How often?
It's very difficult case because of the perio problem in the lower jaw, attrition.
Well, she's got. I'll tell you one thing. She got the attachment loss. I mean, she's at her age 65, but perio is pretty good. She's actually got severe attrition. Okay.
Yeah, severe attrition.
Yeah.
And they're very difficult because if you consider any composite veneer, porcelain veneer, or any crown, there's a chance of attrition in opposing teeth in a lower arch, I mean. So you need to crown all of them to prevent.
It's not even, there's no space to even put anything, I feel like.
I agree. What do you think is the right position? Which tooth has got the best position in the arch?
Which tooth?
Yeah, what would be my reference point when I'm reconstructing? Think about it. I mean, center line's out. So you got a 2-1 moved all the way distally. There's
the 1-2 doesn't look too bad.
1-2 is not too bad, is it? It's actually the right position of the tooth. See, I teach in terms of what to look for. Simplify things. Okay, perio is good for this patient. Most bruxers have good perio. They got bruxer and perio is finished. Okay, remember that Sokransky, when you have a periodontal and a severe bruxer, it's primary, secondary trauma, you lose immediately the infrabony pocket formation. So we all know that. But this is people come in with, and not a lot of them have a lot of money. They just don't have a lot of money. I mean, to fix this mouth, crown, and bridge was a major work. I won't tell you how much. Don't tell me how much would you charge. But I can tell you, in this short course, I'm going to teach you how to go from here to there in one visit. this day down, 23rd May, Sunday. Those who are interested, let Natasha know. Okay, one day.
Yeah. If anyone's interested, the details are in the chat. And you're more than welcome to email us or call us, and we can provide you more information about the course. But we'll also send it as a mailing list, I think, sometime soon in the next few days to everyone that came to the webinar anyway.
How many of you would like to learn how to do this?
Yeah, yeah, we're getting a couple of them. So I'll just send it to you. Yeah, if you guys can just send me an email with your details, and then I'll send you back a copy of the course.
Okay, so I'm going to condense a lot of information in short courses one day. There's a practical aspect to it as well. We'll give you some idea how to do things. Okay, but naturally in a diploma, we do full detail. It's a very dynamic course. I have a dynamic way of teaching. And I get everybody involved. Everyone has to think, and I really appreciate everyone's feedback. I love when I get answers. There's no wrong answers. It actually increases the value of the conversation, where we can talk about things, assess things, and you know, any concerns you have. As a mentor, I help all my students to achieve their best potential and use them. Most importantly, use them in your practice immediately. I'm sorry. Go ahead.
That's just some background noise. No, that's all good.
Question, go ahead.
Has anyone got any questions about the webinar or the course before we wrap up?
All good?
Yeah, I think we're all good.
Thank you so much, Sakis. That was great.
Well, thank you very much. I'm grateful that you all could join in, and we're happy to help. I want you to become the best possible dentists in your practices, for your patients and for yourself. I'm very passionate about what I do. I've been here for a long time. I have case studies wherever you see for years. I have over 25-year case studies. In most of those cases, you know, when we talk about the beginning of the implant course, it's prosthodontics. It's how you plan, what's your final outcome, what's your end point in treatment. So not about drilling a bone and putting it, you know, I can teach a monkey how to do that. There's a lot of monkeys who drill bone, do things, but I want you to think how to restore it. At the end of the day, patient doesn't want an implant, patient wants a natural looking tooth. And that's important. Doesn't matter what you do, you want to make them functional, comfortable, and naturally looking good. That's what the aim is. At the end of the day, how to simplify things, okay? I wish you well, and I'll thank you so much for joining.
And just one last thing, if you guys don't actually send through your email address on the chat, I won't be able to send you the course brochure for the short course. So just make sure you leave behind your email address, guys. Thank you.
Yes, thank you.
Thank you all. Thank you. And Natasha, thank you very much.
Thank you.
Thank you all, everyone.
Thank you, Dr. Sarkis.
Thank you, Doctor. Thank you.
Thanks, Dr. Sarkis.
Thank you. Thank you.
Thank you, everyone.
Thank you. Thank you.
Thank you, everyone.
I'll leave this on so you can write your email in the chat before I switch it off. And Natasha, thanks for helping me.
No dramas.
You there, Dr. Sarkis?
I'm here. I'm here.
I was finding a patient I referred you back in 2006 or 7.
Right.
You know the boy who was pretty much gonna do the suicide with his open bite, a young 22 years old male. Do you remember him? That was a perfect open bite case. Where he came to see me in Bochum Hills saying that the mom was crying and he was crying, and he says, I want to pull all my teeth out and put dentures. And he was 22. And then
I remember it.
Then we did a mock-up, and he was pretty much crying, and the whole emotional thing. I couldn't figure out, I couldn't remember the name of the patient. I kept clicking all the emails.
I'll find these images. We got about 10 terabytes of cases, Nimesh. So it's a lot of cases. And
guys, everyone is still in the chat, so just letting you know.
Okay.
No, that's fine. We haven't started swearing yet.
I'm just giving time, right? So I've got this special search tool to dish out patients' names, right? And it's so fast. Natasha was very surprised. How quickly, Natasha, how quickly was that?
That was genius. I agree.
How quickly? I've been doing search with 10 terabytes, boom, 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 in the case.
I know. I was avoiding uploading a clear correct file the other day, and it took him 1 second.
That's right. It was fantastic. So I'm very happy about this. But a lot of the mock-ups, when we do the course, you see the whole videos, and it's really well organized. I'm starting recording now, module 1, and doing full recordings. So you get your recordings during the in-between when you come for a practical session. So you know all about it. You'd be just asking about the full practical sessions. Those 2 days are very, very important to get hands-on and ask questions. It's really learning. It's ultimate learning, in my opinion.
Thank you very much, Dr. Sarkis. I just want to
thank you very much.
I'm just gonna have the chat. I'm just gonna have the chat open. If the webinar's all done, but I'm just leaving it open for a little bit, so anyone that wants to can leave. No, you just stay. I'm just telling everyone the webinar's complete, but we're just gonna stay on for a little bit so I can collect the information.
No problem.
That's all.
Okay, no problem. I'm just gonna listen to music, okay?
Oh, okay.
Bye, everyone.
Bye. Bye. Thanks for joining us, everyone.
That's okay. Bye.
I'm happy to answer questions.